Let's see who's all here today. Attendees, got a few people in. I'm recognizing some of these names. Yeah, here we go.
It's
Hi, Kim, Monique, Pam, Geneva. You may know some of these names.
possible.
Mhm. There we go.
Mm.
A lot more people signing in here. Okay. Welcome, everybody. And thank you for attending today's session of the community table. Geneva Robinson from 7 counties is going to talk to us today about suicide prevention, which is a public health issue. And she is a wealth of information on this topic. I've known Geneva for many, many years, and
Mhm.
she's a good presenter. She's very knowledgeable about the topic, and it's a passion of hers to help educate people about this topic and give them resources for dealing with it, whether it's professionally or personally. And so I'm just really delighted to have her today. And it is suicide. Is it Suicide Prevention or Suicide Awareness Month?
Suicide Prevention Month.
Prevention Month. Okay.
Mhm.
So it is appropriate that we have her during this last part of this month to talk to us about this subject. So I'm not going to take up any more of her time. I'm going to turn it over to her and let her do her thing. Thank you, Geneva.
Thank you, Laura. Hi, everybody. Thank you very much for joining the webinar today. And I very much appreciate the coalition inviting me to come and talk during Suicide Prevention Month. Um, and in the next hour and a half-ish, I guess, we're going to talk about, as Laura mentioned, some some information in general about suicide for your awareness. We're going to do some education pieces, and I'm going to give you some practical tips on what we can do about it. So that's kind of what we're going to do with our time here today. So then initially, we're going to give you a little bit of background about the scope of suicide, just how frequent it is so that we can understand better why we call this a public health issue. We're going to talk about the impacts of suicide and how this impacts not only the clients, possibly the community members that we work with, but maybe family, friends, others that we might, coworkers that we might care about, just anyone in the community who might be struggling. We'll talk about facts, what we know about suicide and what we know works, and what we can do. And then I'm going to give you some practical resources at the end that you can take away from here as well, so that you will have that information not only for yourself, but to share with your clients, to share with your coworkers, to share with anyone who might benefit from it. So the first thing that I want to do is just kind of begin by setting the stage a little bit. And that's by giving you kind of the scope of the issue of suicide. So just to give you a broad idea, like it says on my screen here, in the world, this means the whole United States, in 2023, there were over 727,000 deaths that were ruled a suicide. And I want to emphasize that ruled a suicide piece, because what we know is that this number is low. This number is low worldwide. This number is low when we talk about US statistics, when we talk about local statistics, because suicide deaths are not always reported that way. And there can be a lot of reasons for that. There's still so much stigma around the topic of suicide that people who are in especially smaller communities or in cultures where suicide and mental health are not discussed openly might be very hesitant to rule a death a suicide. And as you'll see here on the slide, there are at least 23 countries across the world still that in 2023 still made suicide illegal. In fact, in these 23 countries, not only is the act of taking your own life illegal, but an attempted suicide is even illegal. So we know that there are a lot of folks who aren't talking about suicides, and that this number, sadly, is even higher. And a statistic that I think is very chilling is that across our whole world, for folks who are aged 15 to 29, so young people, high school age, college age people, suicide is the third leading cause of death, even with the fact that we know that there are more deaths out there than what are reported. All right, so moving into kind of making it a little bit more local, In the United States in 2023, and I'm going to stop and I'm going to say that all the statistics I've used throughout this presentation are from 2023. And I chose that year because we have the most fully vetted statistics for that year. So the most reliable statistics that we can utilize and feel like we've got good information. So in the US in 2023, we had 49,316 deaths that were ruled a suicide. And then what I want to really point out with this is that just the fact that, as I said, this is not the actual number. We know it's higher. That's still a huge number of people. And there's a huge number of people who are impacted not only in terms of actually taking their own lives, but in the number of people who've thought about suicide very seriously. As you can see, the number of folks who've actually made a plan and the number of folks who's actually made a suicide attempt. So you can see that this is all these numbers are in the millions of these. Now, one thing that we do know that some research has found is that attempts at suicide is an incredibly low number. It's estimated, and where this number comes from is that for every death by suicide, there are at least 25 attempts. So for every actual death, at least 25 attempts. But in the young population, so ages 13 to 24, in that young population, it's believed there may be as many as 200 attempts for every suicide death. 200 attempts. So what that comes down to in terms of what we know for sure, in terms of the loss, is that there is one death by suicide in the United States every 11 minutes. So just in the time that we're going to be talking today about this important issue, every 11 minutes, someone else in the US will have lost their life to suicide. All right, so why do we need to talk about this? Well, other than the fact that, this is something that, as we said, is a public health issue and impacts us all, it's important for us to know kind of where this is in the United States for different groups. And overall in the United States, suicide is the 11th leading cause of death. So it has been also in the past during COVID, it was the 10th leading cause of death for a period of time. But pretty consistently, it has stayed as the 11th leading cause of death for all ages. Now, I think what's interesting to point out about it is that homicide is the 16th leading cause of death when you rank things. And there are about 22 to 23,000 homicide deaths every year in the United States. And so there are more than double the number of folks in the US who die by their own hand every year than die by the hand of someone else. But we're not always aware of that information because suicide isn't what you hear about all the time in the news or any source that you pick up online. We hear more about homicide, the epidemic of homicide, the threats from homicide, and they are, and we absolutely need to look at that as a threat as well. But what you don't hear is you don't hear the same kind of rally and cry for us to address suicide as that public health condition or as an epidemic. We also don't necessarily see the same resources being put toward addressing the root issues and the symptoms around suicide as we do around homicide. So I think it's important for us to know exactly where that falls in the continuum. But again, as we said with the world, the news is even worse for other ages. So for our young people, ages 10 to 34, it is the second leading cause of death in the United States. The only thing that more folks in this age category die by in the US each year than suicide are accidents. And we truly believe that a lot of things that are ruled as an accident were actually reckless or life-threatening behaviors that we're undertaking purposefully. Things such as a car accident, where the weather is fine, there's nothing wrong at the road, but somebody's traveling at an incredibly high rate of speed all alone on a road and slams into a tree without applying brakes. Sometimes these accidents may actually have been attempts to take their own lives. For ages 35 to 44, it is the fourth leading cause of death. And for 45 to 54, the fifth leading cause of death. And then for the 55 to 64 category, it's the eighth leading cause of death. So we have these age categories that we're aware of that have risk factors that make them more likely to carry through on a suicide attempt. And something we often don't give a lot of thought to in our society is the folks who are our older population, 85 and over. And when I say they have the highest rate, their numbers are smaller, but that's because their numbers are smaller in our overall population. But compared to the percent of population that makes up this 85 plus category, our elderly folks have the highest rate of suicide. And along with that, they often are most likely to be ignored in terms of their mental health, or to have it be devalued in a sense, to just say, well, they're just old, they're slowing down, they have dementia, rather than recognizing that older individuals also have and live with depression, and they have anxiety, and they have a huge number of losses often. And so this is often an overlooked part of our population that we want to make sure we're remembering. Another reason that we want to talk about suicide, and one thing that we want to know, is that we can tell through research and through the reports that are ruled as suicide, how people are choosing to end their own lives. And by far, as you can see on this chart, the vast majority of people take their own lives via a firearm, using a gun. So 55%, or just over half of the folks in the United States, that's the weapon of choice. So why is it important to know this? It's very important to know this because when we're talking about suicide prevention and awareness, counseling on access to lethal means, helping people understand how dangerous it can be for a person in their life or someone that you're working with to have an easy access to a firearm, that greatly increases the chance that they're going to carry through on a suicide attempt. And a firearm is a very deadly suicide method. There's rarely, if ever, a chance for a built-in rescue if someone chooses a firearm as their method, whereas there may be a chance if someone takes an overdose or cuts their wrist or does some other type of intentional self-harm, there may be a time period where they could change their mind and they could reach out to somebody and someone could help get them to safety. With a firearm, that is rarely a possibility. So it's really critical that we understand just what a role firearms play in the suicide deaths in the United States. Now, in Kentucky, we follow along to a large degree, similarly to the rates and different pieces of information that apply to the United States. But unfortunately, this is one area where Kentucky actually has a higher rate and rates higher than many other states in terms of suicide deaths. And having just talked with you about firearms, I'll bring your attention to the last bullet point or point down here on my slide. So in the nation, a little over half of folks die by suicide via use of a firearm. In Kentucky, that number's much higher. So it's at least 64% of folks in Kentucky die by firearm. In years past, in particular in the years of COVID, that statistic was over 70%. So by far, the majority of folks in Kentucky choose a firearm as their method for death, for suicide. We had 813 deaths by suicide in Kentucky in the year 2023, and that's about average. Kentucky pretty much always has in the low 800s is the number of deaths that are ruled as suicide, and that's been relatively consistent for a long period of time. Out of all 50 states in the United States, Kentucky ranks 20th in the US in terms of rate of suicide deaths. So the rate of suicide deaths per 100,000 occupants who live in the state. So this is not an area we want to be higher up on the ranking in. There's so many others that we really would prefer that we rank higher. Much like in the national statistics, for ages 10 to 34 in Kentucky, it is also the second leading cause of death. So we, again, have more of our young folks in our state dying by their own hand than we have dying at other people's hands or by so many other of the illnesses and reasons that we see and hear about all the time. And importantly, Kentucky has unfortunately been slowly increasing in terms of our suicide rate, not necessarily our numbers, but our rate. And over the past 20 years that we have had good data, we've had almost a 40% increase in deaths by suicide. And that gives us a much higher rate than the general US, unfortunately, almost 50% higher than the rate is throughout the US. And along with the statistic about our young folks having a higher rate of suicide, I think that this is a very telling statistic to be aware of for any young folks that you might find yourself working with or that you care about in your family. One self-report that was done by the National Institutes of Mental Health found that 1 in 7 high school students reported in 2023 that they had seriously been considering suicide. So not just vague thoughts, but seriously considering taking their own lives. And 1 in 5 of those middle school students, younger kids, also reported seriously considering suicide. And just to kind of give you the sobering truth of this, we have had suicides most years that I have been in this field of someone under the age of 12 in Louisville, Kentucky. So almost every year we've had a middle school student who has died by suicide. So taking it and breaking it down a little bit further, since I'm talking a little bit about the Louisville metro area, Louisville Metro has a first ever report that was released last week by the Jefferson County Suicide Fatality Review Board. And this is a group of mental health and emergency services professionals, ULaVell epidemiologists and clinicians who have come together to review data around suicide deaths in our community. And the reason for reviewing this data is so that we have an accurate picture of what is happening in the Louisville metro area, but more importantly, that we're able to look at targeted prevention efforts to be able to address populations where we're seeing high rates of suicide. So some of the results that the report came out with for 2023, in Louisville, we had 143 deaths ruled as suicides in 2023. In 2024, that number is higher. That information has not been officially released, but it is closer to 200 deaths. And unfortunately, I'm sad to say that so far for 2025, we're on track to have a higher rate at the end of this year as well. So that's an increase over the last 2 years of over 31%. So just like we've had an increase in Kentucky, we are seeing that same similar increase in Louisville Metro. In the metro area, we very much mirror our state statistics that the majority of deaths, almost 2/3 of all deaths by suicide, are by firearm, and that the vast majority of all suicide deaths in Louisville are deaths of men. Men make up almost 77% of all of the deaths in Louisville. And the vast majority of those males who are dying by suicide are non-Hispanic white individuals. Women have a much smaller rate of death by suicide and a much smaller rate of that more lethal means of firearm suicide. An interesting statistic that sometimes is a little bit confusing, but puts this into stark view. We know that in the United States, men die by suicide. Men die by suicide 3 times more often than females. But females attempt suicide 4 times more often than their male counterparts. So women attempt more, men carry through on a suicide attempt that is lethal more often. The difference there, pure and simple, is the means and the method that they use. And as you can see here, because the vast majority of those deaths by men are by firearm, which is the more lethal method that they can use, much smaller death by firearms for women. Women are more likely to choose the less, we might say, aggressive forms of suicide methods that do have that built-in chance for rescue. One thing that I want to also point out, though, that was very interesting that this study found was that in the last couple of years, from the pandemic years, 2020 to 2022, in our Black and African American community in the metro, we saw over 100%, 126% increase in deaths by suicide. So that tells us that this is a community, a cohort of individuals that we want to make sure we are addressing directly, and that we are creating prevention materials that will reach this population and be effective for trying to put a stop on this rise, because that's a scary increase. I also wanted to kind of talk a little bit with you guys about some special populations. We've looked at some of our age groups and ethnicity indicators that have higher suicide risk or higher suicide deaths. But we also want to talk just a little bit and highlight a few special populations, many of whom you may work with, you may identify with, or have someone you care about in your life that identifies with these. So the first is our population, our individuals who identify as LGBTQ+. And we know that in the overall all age groups who self-identify as LGBTQ+, those folks are 4 times more likely to make a suicide attempt than folks who do not identify as LGBTQ+. So they're far more often to carry through with a suicide attempt, and they are more often they do die by their suicide attempts. For the younger ages of folks who identify as LGBTQ, the 13 to 24 age group, there's 1 attempt estimated every 45 seconds. So less than a minute, there is an attempt somewhere in the United States by a young person who is struggling with their sexual identity and not finding the help and the support they need to feel like they have the right to stay alive. That's a scary thought. For all ages who identify in this group, 39% in the year of 2023 self-reported that they had seriously considered suicide. So over a third of those folks of all ages. And for transgendered and non-binary youth in our communities, that's an even higher number. Almost half of all folks who identify as transgender or non-binary in this young folks group had seriously considered suicide in that given year. So this population group, we know, is adversely affected as one of the major contributing factors by safety issues. And when I say safety issues, I don't just mean their risk of suicide. I mean the fact that they don't feel that they are safe emotionally to talk about their orientation. They may not feel safe physically, especially in a heightened sense of polarization and calling out of people who are different from the norm that we're experiencing right now throughout the United States. Their physical and mental, emotional safety all feel threatened. And this is really contributing to the higher rates and the rising rates for this population. A second population that we want to highlight are our veterans here in Kentucky. We have a much higher rate, again, in Kentucky, unfortunately, of suicide death rates for veterans than the US average. So it's about 32% higher in Kentucky than it is across the US. And what that comes down to is that in Kentucky, every year of that 813 suicide deaths, about 100 of those every year are deaths of our veteran population. The highest rates are in our 35 to 39-year-old veterans, many of whom are coming back into society, perhaps from a stint in the military, whether that was an active duty stint, a reserve stint. They're trying to kind of find their new normal in our society, and quite often that proves to be very difficult. For many of our veterans who have actually served in military actions, there's a high rate of post-traumatic stress disorder. And that high rate of post-traumatic stress disorder is superimposed over other issues that they might be experiencing with reintegration, with reestablishing relationships, with trying to find that new normal, trying to find a place where they feel like they fit. Those thoughts and feelings and those extreme situations that they've experienced don't just go away. So we know that those high rates of PTSD are also a major contributing factor to the higher rates of suicide attempts and deaths in our veteran population. The next special population group that I wanted to talk a little bit about is the population group that many of you on this call are an expert on, and that's our unhoused community members. And as you may be aware, you may not be aware, persons who are experiencing homelessness have a much higher rate of suicide than do the housed, and then do in general everyone across the United States. It's estimated that they have a 9 times rate of suicide to the public who is housed. So 9 times, that's an enormous difference. And more than half of all people who are experiencing homelessness have had some thoughts of suicide or have actually made at least one, maybe more, suicide attempts. We also know that children are disadvantaged by this as well and are affected at a much higher rate. And children and youth who are unhoused, they're at 3 times higher rate of making a suicide attempt than are their cohorts who live at home, live with a parent or a guardian. So that's a 20% rate versus a 6% rate. So they're at much higher rate due to their situation of experiencing homelessness. And research has found that when you compound identification with the LGBTQ community with a young age, and someone who's experiencing homelessness at that young age, they're 2 times as likely to die by suicide as our heterosexual youth who are also experiencing homelessness. So what we see here is a compounding factor, that you have so many of these stressors, each of which put an individual at higher risk, coming together in some of our very vulnerable populations and creating these increased risks of attempts and actual deaths by suicide. With our unhoused community members, as you are very well aware, I'm not telling you anything new here, they face a multitude of psychosocial health problems, financial issues, physical safety issues, all of which sort of combine with the past traumas that they may have experienced throughout their whole life. There's a reason that they find themselves unhoused. And those reasons generally are related to some type of issue that could have been a traumatic event or a series of traumatic events that have led them to the place where they are. They've often been the victims of violence. They often continue to be the victims of violence. They lack often any connection to reliable support systems. Often the support systems that they perhaps are able to find and form are transient. May be there at some times, but possibly not when they need them the most. And they have a challenge very much in taking care of their basic daily needs, like getting enough sleep, eating enough, being able to obtain and to take medications. And that's a big issue that we don't always necessarily think about, but especially for folks who may have chronic illness diagnoses or folks who may have a behavioral health diagnosis, medication can make the difference between life and death. It can make the difference between whether you are able to be productive in society or to even take care of yourself. So if you're not able to consistently have access to and take those medications, that puts people in a very dangerous position in so many ways. And one thing that we know happens with folks who are unhoused is that all of these daily, often traumas that they're experiencing through violence, through victimization, through degradation and discrimination, all of these things sort of skew and change the person's ability to make good decisions and to prioritize in any way their own health. Why? Because they have to prioritize survival. So the things that we might take for granted that we do in our life to feel healthy and happy are compromised by the multitude of stressors and external and internal that are working on someone who is trying to survive on the streets. We also know that many of our unhoused community members also are living with not only a health condition that impacts their ability to care for themselves or others, but also may have an undiagnosed and or untreated behavioral health disorder. One study that the National Healthcare for the Homeless Council has conducted found that 68% of homeless individuals self-reported that they had had a significant level of psychological distress in the past month. So there's a large number of folks who are reporting that the distress is there and it is not going away. It's something that they carry with them. And then that distress is exacerbated not only by being in the elements, at being at risk for violence, but by a health system that doesn't make it easier for them to get help even if they reach out. It's very fragmented. It's not comfortable often for the unhoused population to be able to get to help. So they often turn to trying to self-medicate, self-treat for the distress that they're experiencing or the physical symptoms that they're experiencing. And this can lead them to misuse emergency services or to only use emergency services, to not get any type of preventive or maintenance ongoing types of healthcare, including mental health. So it's not until they reach an emergency situation, and in some cases that means a suicide attempt of some type, that folks reach out and actually attempt to get any sort of help. And what this leads to, that is the most important in terms of predictors for suicide, is that it leads to a sense of helplessness and hopelessness. And something that we know from research and from experience on lines like the crisis line that I'm a part of, is that hopelessness is the emotion, the feeling that is most closely correlated to someone carrying through on a suicide attempt. And if you think about it, that makes sense. If I have no hope whatsoever that I can ever feel better, if I have no hope that things can ever change, if I have no hope that anyone is willing to help me, if I have no hope that I deserve help or I deserve to be healthy, then that leads us to feel sometimes that the only answer to get out of the pain that's being experienced is through taking our life. So that sense of hopelessness that comes as a combination of all these very difficult barriers and challenges that are experienced by our special populations, if you will, all kind of form together to be a very difficult sort of cloud of problems that individuals themselves can't always address or take care of. And that's why we say suicide is a public health issue. We say that because it requires a serious public health community response in order to address all of the underlying factors that influence a person toward a suicide attempt. We know that every suicide attempt, what goes into the person's feelings of hopelessness and helplessness, what gets them to the point where suicide looks like the only option. They're in that tunnel and they think that's the only way to find relief. That isn't just one thing. It's usually not just two things. It's usually a whole bunch of things that are working together that are pushing them in that direction and taking away their ability to feel that hope. So we know that the solutions to all of these problems also have to be multifaceted. So that is a reason that we want to say that this is a public health issue. We also know it's a public health issue because we know that folks beyond those who actually die by suicide are greatly impacted by the aftermath and the consequences. And what national studies have found that for each individual who actually dies by suicide, there are at least 6 other very close or significant relationship people in their lives who are tremendously impacted by the death, and for whom their life danger rate of falling through on a suicide attempt is greatly increased. In fact, those 6 people, it is estimated, have a 6 times higher likelihood of themselves making a suicide attempt at some point in their life than do folks who have not been impacted by suicide. And this rate is believed, this impact is even greater when the individual impacted is a child who has lost a parent or a guardian or the person who served that role in their life. So if a child grows up with having had a parent, someone that they look up to, who cares for them, that they trust, who has chosen suicide as the way that they get out of pain, the way that they have ultimately handled and dealt with stressors, then that child grows up with suicide always being an option on the table. For other folks, it may take a little bit further to get past sort of our self-protection that is inbred in us, that's inborn in us, that we want to live. They grow up believing that if things get too bad, that's always an option. So that greatly increases their risk across their entire lifespan. And our suicide fatality review work group found a statistic that we hadn't expected, that we were surprised, but that made sense in looking at this public health issue angle for suicide. And that's out of all the deaths in Jefferson County that were ruled suicide, we found that a significant other, a loved one, was either present and witnessed the actual death or was present immediately following the death. In other words, found the individual who died by suicide in almost a third of all the situations. So 32% of all suicide deaths. So we know that those folks have experienced a unique sort of trauma that is going to impact them as well. And it will be difficult for that to not cause them also to feel helpless and hopeless and in despair. So all of these factors together require that as a society and as a community, we all look at what role we can play in reducing rates of suicide. So all of that together is sort of, I don't know, the bad news, I guess, or putting it into perspective of just how much of an issue suicide really is, and how many of us are impacted by this, even if it's not directly. But what I want to also do, what I want to spend the rest of our time really doing are the positive pieces in a sense. Because I want to talk about what we know. And what we know and what we can do are bound together. So the most important thing that I want to say, and that I would like for you to take away from this presentation, if nothing else, is that we know suicide is preventable. There are evidence-based treatment programs that make a difference long-term, but more importantly, there are very simple, don't cost anything or low-cost day-to-day interpersonal interventions that we can all do, every one of us, that truly make a difference in whether someone carries through on a suicide attempt or not. So what you're doing today by giving your hour and a half to come to this presentation and on a gloomy, rainy day, talk about the topic of suicide, being more aware is that first step, understanding that this is something that as a community, we can't just ignore, is the first step for that. And the second step to that is that you're willing to help. Now, you may not know how to help, and you may be thinking in your mind, well, nobody trained me in school on how to talk to a suicidal person or what to do or any of that part. That's okay. You don't have to be an expert on how to lead people all the way to wellness. What you just have to do is have a caring heart and an open mind that says, I'm not sure what to do, but I sure want to try. I'm sure open to learning. And keeping your mind open and being willing to learn more about how you, on an individual level, can make a difference and help will go a long way toward overcoming some of the barriers that get in the way of someone reaching out for help. And the biggest of all of these, that we have to deal with, is stigma. And I mentioned it at the beginning of our talk here, in terms of us not really having a great idea of how many deaths in the US really are suicides, because people don't want to say they're suicides and a coroner's office doesn't want to rule them a suicide. So much of that's about the stigma. It's about the blame that the family members who are left behind might put on themselves, or that they feel other people's will put on them. It's about the stigma that exists in our society for talking about anything around mental health. People will tell you all sorts of things about them. They'll confess their secrets to you. They'll tell you they're, having financial problems. They'll tell you a lot of different difficult and personal things. But most people are not going to be open and volunteer to talk about their own suicidal thoughts and feelings. That's really hard for folks to do. That stigma gets in the way. Folks can feel very much like, if I talk about this, people will see me different. If I talk about this, people will think that I can't handle anything. And that feeds into low feelings of low self-worth and low self-esteem and I don't matter, that are often already a part of the suicidal individual's thought processes. So anything that we can do that breaks through that stigma by being the first to reach out and to learn and to be able to talk about this topic, that's going to create an environment that feels more welcoming and open to all the folks who are fearful and think that they can't talk about it. But the fear isn't only on the part of the folks who are suicidal, I think sometimes. I think for a lot of us, especially for those of us who who maybe haven't had any sort of mental health training, perhaps in our lifetimes, or didn't go to college and get a degree in psychology, but for any of us really, because I will tell you one thing that we do know, even in our field, for those of you who are watching, who are listening, who are social workers or who are therapists, clinicians, suicide is not something that you get a lot of training in, even in your graduate school training. You know, we talk about all the symptoms, or, you know, we talk about medical health diagnoses, we talk about those treatment plans, but we don't talk specifically about suicide as its own individual issue and about how we prepare for that, how we intervene, and what we can do to reduce the rates. So we know that. So one of the most important things that anyone can do to preventing suicide is being willing to talk about it. But sometimes the fear on the part of a potential helper is there that we don't want to talk about it. We don't want to ask someone, hey, are you thinking about suicide? Or I'm worried about you. Something doesn't seem right. I'm worried that you're thinking about killing yourself. And the reason we don't want to ask that question is because we're afraid they're going to say yes. And then if they say yes, we have to do something about it. And we're not sure what we need to do. We're not sure how concerned or worried we should be. And that comes not from ignorance, so to speak, but from a lack of information. So one thing that we want to spend a few minutes doing today is just kind of going through a little bit of the information that can help equip you to reduce that fear that you might have of reaching out to someone that you're concerned about who might be having suicidal thoughts or feelings. So you can be the one to make that first move, to be able to show that talking about suicide is not a taboo topic, that this is something that you're a safe person for that individual to bring to you. And that's incredibly important for people across the ages, all age individuals in our community, but it's especially, I think, important for our young folks and for our special populations we talked about who are already experiencing so much stigma in other areas of their lives as well. So, what do we know about when we need to talk up, when we need to speak up, or when we need to ask, or we need to find something more out about how close someone might be to considering and carrying through on a suicide attempt? There are two things that we can learn about, and then I'm going to give you a little bit of information about today that can better equip you to know when it's time for you to ask those questions and for you to step in and say, I care. And the first set of information or facts that I want to give you is that we know that there are certain risk factors for suicide. Through research and through treatment and working with individuals over the years, our statistics have shown us that there are factors which are just conditions or circumstances that may exist in an individual's life or occur in an individual's lifespan that increase the likelihood that they will make a suicide attempt. And so there are three categories of these risk factors that we like to think about. Long-term, which means conditions or circumstances that pretty much folks are born with or which are present from the time of birth and that people grow up with, so to speak. These are our high-risk groups that we've identified and know. Then there are also short-term risk factors. These are circumstances or conditions that may develop or happen to someone externally or internally throughout their lifespan that may also help us predict that someone may be more likely to harm themselves. And then we have precipitating risk factors. These are sometimes called the trigger event. Not a great term to use in suicide prevention is to say trigger, but that's sort of a common parlance often that's used. But the precipitating risk factors could be that recent life event, something that happens that challenges and overwhelms the person's ability to continue to cope or to keep things balanced. It's that last drop of water that overfills the glass, so to speak. So the long-term risk factors are kind of pretty simple and straightforward. The first couple are, unfortunately, in the United States, for those of you out here who fit in this category, if you are a white male, we know that you all have the highest rates of suicide. You know, we looked at the numbers earlier when we saw that. We know that white males are more likely to choose more lethal means for their method of suicide. So just those two factors that someone is born with are absolute risk factors over the long term. We know that, again, being part of the identifying as LGBTQ plus, that is something that we're born with. It's not a choice later in life. It's something that we're born with, but that also puts folks at a higher risk, again, especially for younger people. Adverse childhood incidents or trauma, those are, I mentioned earlier that if a child grows up in a household where a significant family member, a parent, a guardian dies by suicide, that introduces that to the child as an option. So they grow up having that option. Many of the traumas, be they sexual abuse, be they physical abuse, mental abuse that folks may experience throughout their life from their family of origin, those traumas build and make it more difficult for anyone to feel like that they deserve help. They work on folks' self-esteem, and they don't always allow an environment in which a person grows up to feel that they have value. We know that growing up in that way with those series of traumas makes someone at a much higher risk of carrying through on a suicide attempt. And that goes along with that history of violence and limited access to health care, whether for physical illness or for mental health conditions. That also starts often from birth and persists. So when folks have serious physical illnesses, that puts a drain, so to speak, on their coping mechanisms, their resiliency, their ability to be able to handle the traumas and the stressors that may come along, those short-term risk factors they may experience later in life. We also know that folks who grow up to be diagnosed with behavioral health disorders, not all of those happened in adulthood. Many of those were undiagnosed and untreated when a person was very young. And so they have been experiencing the symptoms that go along with those illnesses and that lack of treatment for a long period of time. And that risk has simply grown and grown over time. So these are the risk factors that we kind of have in the background, that we know that folks who are a part of these groups already, unfortunately, have a higher likelihood through their lifetime, should other intervening instances or circumstances happen, of becoming suicidal and for carrying through a suicidal attempt. Short-term risk factors, there's a lot of them on here, and some of them we've talked about already, like trauma that can not only happen from birth on, but can happen later in life. Discrimination, violence that we've talked about around some of our special populations, and that threat that they have to their physical, mental, emotional safety. But a couple that I want to highlight that are especially important for us to keep in mind in terms of people who might be at higher risk are that history of mental illness, and in particular, a history of depression. Now, we know from psychological autopsies and from research that in about 90% of situations where a person dies by suicide, there was untreated and usually undiagnosed depression present at the time of death. 90%. Now, what that doesn't mean is that everybody who lives with depression, even a diagnosis of major depressive disorder, absolutely not everyone who lives with depression ends up trying to kill themselves. But in 90% of the cases, that has been found to be a complicating factor that is there. So it's really important for us to understand and know that individuals who live with depression, that is a factor that we have to take into consideration, because it is one of the strongest predictors that someone will actually follow through on a suicide attempt. Along those same lines is if someone has had a previous attempt at taking their own lives. And we say often in our field of suicide intervention that suicide attempts are sort of a progressive behavior. And here's what I mean by that and why they're so important. Sometimes people will make a first suicide attempt, and it's more what we have called in the past often a gesture, where they might take some action that could result in loss of life or death, but they really don't take it in a way that ensures that they will die. That built-in piece of rescue we talked about earlier that comes with some types of methods. So they may make a suicide attempt where, for instance, they cut at their wrists, but only somewhat superficially. or they may take an overdose of a medication, but not enough to actually make them lose their lives. So if that is something that people attempt, maybe in an effort to get someone else maybe to understand and to see how much they need help, that doesn't work. If they make that attempt and they don't tell anybody, or no one notices, and or they don't get the help they need, or even worse, it makes people angry. They get in trouble for doing that. Why are you doing something stupid like that? Why did you do this to me? If that's the response that they get, then that only compounds the feelings of low self-worth, and I don't deserve to be alive, and I'm a burden, and nobody wants to help me, and nothing's ever going to change, right? If they don't get help, then they're going to continue feeling that desperateness that they've experienced when they made that gesture. So what we usually see is a cycle that happens. And so then the next time people reach that point where they can't take anything more, when they experience a precipitating factor, something in their life that's that last drop that overflows their cup, the next time that they make a suicide attempt, they're going to try a little harder, for lack of a way to say that. They're going to take a little more pills. They're going to cut deeper. They're going to do something that's a bit more dangerous because they've already stepped across that self-preservation line that's very hard to get across the first time. And they now have the capability to set aside that self-preservation and to see suicide as a viable option. So anyone who's had a previous suicide attempt is definitely at a higher risk of suicide than someone who has not made it to that point in their process before. When you couple a current episode of untreated depression with someone who has had previous suicide attempts, that definitely puts that individual at a much higher rate. And the slide into the wanting to act on those feelings and those emotions is shorter and faster for folks who have that capability. The precipitating factors for suicide, what you can basically see it looking at my slide is most all of them are around the loss. Some loss that feels threatening, overwhelming, unbearable to an individual. And that loss is defined by the individual who's experienced, and what that loss particularly means to them. So it can literally be just about anything. The most common losses that precipitate someone to make a suicide attempt are the loss of a significant relationship. Now, that might be through a death of a family member, a friend, somebody that you care deeply about. It might be a divorce. It might be a boyfriend, girlfriend left me situation. But it can also be the loss of a significant friendship. So maybe someone who had been sort of your lifeline, who had been the one that you went to, that helped pull you out of that abyss when you needed it. A breakdown of those relationships can feel like a breakdown of everything that kept you alive. Sometimes it's a loss of a pet. There are two kinds of people in the world, I always say. There are the pet people who their pets are their family, and then there are the people who don't really understand the pet people because they're not, their pets are not their family. They don't have pets, neither right or wrong. But for the people who are pet people, that is a family member that you lose quite often if you lose that companion. And so we often find that is overlooked in terms of possibly being a last straw precipitating factor that might lead someone to give up. This is particularly true in that the older elderly population that I spoke of earlier, where they have such a high rate of suicide compared to the number that they make up in our population. And quite often, for some of our elders, they may have lost most of the people that were in their lives. They may have, their children may have moved away, or they may have lost spouses. They may not have any siblings left. They've lost their parents, of course. So their pet may be the one thing that they have that gives them a sense of purpose and a sense of belonging and a sense of companionship. So whatever that relationship might be that is sustainable and that feels unsurvivable to an individual, those are the events that we most often see that push people kind of over that edge and past that self-preservation. Now, there are also some situations that compound these other factors as well that we know we need to be very aware of. That's the presence at the time that this precipitating factor happens and the aftermath or the impact of the situation. The presence of alcohol or drug use definitely clouds people's ability to make good decisions or to be able to accept help from other people's or even be able to reach out for help. So the presence of alcohol or drug use at this time of danger exacerbates and makes things a lot more dangerous for folks. We often know that a recent discharge from hospital, especially a psychiatric facility where someone's gone for treatment for a mental health or psychiatric disorder, when that person is released from the hospital and they're back home in the same environment that they were in before, they may or may not have learned the coping mechanisms and be able to apply those that would help protect them. So that can be a very dangerous time for many folks. And in that same vein of thought, it's interesting that although depression is present when folks, in 90% of the people who carry through and die by suicide, we might think that when people were in the deepest, darkest, mud of depression, the really bad times, that might be the time that they're at the highest risk of wanting to die and killing themselves. But what we found is that's really not the case. When someone is in that deep, dark mud of depression, it may take every ounce of their energy and their thought processes to be able to even get out of bed and change into regular clothes. It may be that person can't even get themselves motivated enough to eat. They probably don't, in that depth of that depression, have the mental and physical capabilities and just plain energy to put together a suicide plan, to go seek out the methods that they would use for suicide, to buy the means or to get the means together that they would use to carry it out. They just don't have the wherewithal to do that. But when someone first begins to recover from that deep, dark depression, perhaps they've just started going to see a therapist, or they've just gotten in to work with a social worker. They've had a little piece of hope given to them with that. So that might alleviate some of those really extreme feelings that go with and reductions in energy and thought process that go with the deep depression. But they haven't worked their way through their traumas or through the depression to understand what they need to do ongoing to stay feeling better. They may have just started medications to help with their depression. And as we kind of know in our intellectual brains, at least, most psychotropic medications don't just start immediately. You don't just pop a pill and all of a sudden you're feeling better. It takes a while for those to build to therapeutic dosage, right? So in that in-between time, before the medications or the therapy is able to, de-escalate and equip an individual to handle the stressors in their lives, they still have those stressors to face. So quite often, the hope of beginning treatment fades before the promise of completing treatment and moving on to a healthier life is fully realized. And it's in that in-between time that people have the energy and they have the ability physically to put together and make their plan, get their means, and possibly carry through on a suicide attempt. So those are some of the risk factors, in addition to the sense of loss, that we may not always think about, but that we need to have in the back of our minds. If we know a client or an individual who's having these experiences, that should kind of let our alarms go off in our head that we need to be more aware of what is happening with them and where they might be in terms of suicidal thoughts and behaviors. And as we mentioned previously, a suicide attempt is a strong predictor that someone will try again to take their own lives. So someone who has recently made a suicide attempt, in particular in the last 2 months, is at a much higher risk of trying again if they're not getting the help that they need to address the underlying issues. And you'll hear me say an awful lot this, but we'll say it again: firearms being the most lethal method of death by suicide chosen by the vast majority of individuals. If someone has very easy access to firearms, they're always in the home, they can get to them, there's nobody to help them by getting a gun lock and putting it on or putting it out of their reach, that greatly increases the possibility that, especially in a fleeting moment of extreme pain, Someone might act somewhat impulsively and use the gun, whereas at another time, if they had a little bit of space and difference to reach out for help or to let those transitory intense emotions abate, they may not actually take their lives. So that easy access to firearms is a critical risk factor that we need to always be aware of and thinking about. Okay, so we've talked about risk factors, those circumstances or situations that we can be aware of that tell us through research and through experience that somebody might be more likely to carry through on a suicide attempt. So the other piece to that then is if we're aware of those risk factors, then we want to be also looking for and thinking about warning signs of suicide. And these are the outward signals, the things that someone might be saying or ways they might be behaving or acting, or both, usually some combination of both, that would tip us off even further that not only are the risk factors there, but the danger is there that they might be moving closer to considering suicide to be the option. And what we can sum up all risk factors into warning signs into some degree is changes in personality, expressions, relationships, and or behaviors that are different for the individual. They're not expected. They're not what you usually see in terms of the individual's interactions or behaviors. And these are not changes that the individual has communicated that he, she, or they have planned for or are working toward. These are changes that just seem to come either for no reason, or they're changes that seem to be negative in a sense, that seem to show feelings of unhappiness and of distress. And especially if those changes are noted and noticed at the same time that one of these painful events of loss, one of these precipitating factors, one of these precipitating events may have recently happened in a person's life. When you put those things together, we definitely have to be listening for and watching for those warning signs. And the warning signs, as we said, can be somewhat subtle. It might be something that the person says or something we observe them doing. But they are those changes to keep in mind. Things like, that you hear a lot about: sleeping too much or too little, eating too much, not being able to eat at all. Those are things that we might see. Folks might be more irritable. Someone who perhaps had always sort of been the life of the party or very socially active with a group of family members or friends becomes withdrawn. They're no longer reaching out to other people nor responding when you reach out to them. It might be someone who had a normal energy level and was relatively, productive in their day-to-day life, suddenly feels tired most of the time. They never feel like doing anything. They neglect their personal appearance or their home. Things begin to pile up. They're not able to clean. They're not going to get their groceries. They're not taking care of their physical health. Folks may write about suicide. They may journal about it. With children, we often see suicide as maybe a topic of their assignments if they're asked to do writing assignments. All of these are things, behaviors and expressions that we can see or hear. But the ones we want to really focus on are when somebody talks about their feelings, the emotions that they're experiencing. What is that psychic pain that's pushing them to a point where suicide is the only option? And the feelings that we want to listen for and watch for expressions of the most are feeling hopeless. And we talked about that earlier, why that makes sense. And we do know through research that the emotional state, emotional feeling that is most closely correlated with someone actually making an attempt on their life is that hopelessness. That's the one that is most likely to be that final driver. But also feelings of worthlessness, that low self-esteem that says, I don't even deserve to be here, that I'm trapped in the pain that I'm experiencing. There's no reason for me to keep trying, no purpose for my life. There's no reason for me to keep trying to fight this because nothing will change because of that hopelessness. Those are the emotional expressions that we want to be very sure we are listening for and giving great worth to when they come up. We also want to look um, for acting out behaviors, if you will, or reckless behaviors. And I want to say this one is particularly true in terms of young people. Quite often in children and in teens, one of the first things that we will see that are warning signs that might be missed by their family members or friends are behavioral issues they get labeled. Maybe that happens in school, that they're acting up, acting out, they're not following the rules, they're getting in trouble, they're starting to fail classes. Those sorts of behaviors are often a young person's only way to try to express the intensity of the emotions they're feeling. So when we see those behaviors, again, particularly when they're new or when they have increased and intensified, we absolutely need to be sure that we are checking that out to make sure there's not something deeper going on, that that's not a young person's way of trying to tell us they need help. And there's kind of a myth that has always existed around suicide, especially in terms of young people. If they're acting out, oh, they're just trying to get attention. Don't buy into that. Don't play into that. They just want attention. And what I would say is, yes, that's exactly what they want. That's what they need. They're trying to tell you that they need help and they don't know how else to get your attention so that you can give them help, guide them to the help they need. So we definitely want to be sure that we're not passing those sorts of behaviors that are really help seeking through the language that a young person is able to express as those being just a behavioral issue that needs to be punished, if that makes sense. So we want to be sure that we are taking those seriously, and especially if someone is mentioning suicide. And there's another myth that says that folks who really talk about suicide, again, they don't really mean it, or they wouldn't talk about it. The people who really mean it and are really going to kill themselves, they don't talk about it. They just do it. But that's not true. We know that in over 80% of situations, if you go back and trace people's weeks and months before they actually made a suicide attempt, you will find that they made outward suggestions and even verbal mentions of suicide, or a veiled sort of allusion to suicide, like, well, I won't be here any longer, or what's the point of living? You won't have to put up with me anymore. And very, very importantly, people who think that they are a burden on the folks and the individuals that they love. That expression that I'm a burden, I don't want to hurt you anymore, is also a very strong predictor that someone is considering suicide as their last option. And we've even found from survivors of attempts that they will describe that feeling of a burden sometimes as leading them to the belief system that if I love my husband, my wife, my mother, my father, whoever is your significant other in the world, I really, really love them. I love them enough to stop burdening them. That the best thing I can do for them is to remove my worthless, shame, guilt-ridden, terrible self from being their burden. So they really can, in their mind, have distorted thinking that feels like suicide is an act of love. And that can be very difficult for folks to understand who haven't experienced that, but that's important to know. And why we say that folks who are putting their affairs in order, saying their goodbyes, giving away possessions, and who express that feeling of, I need to stop being a burden on other people, those folks are at very high risk and are communicating that they feel like they are doing what they need to do, not only for their own pain, but for the pain and the hardship that they perceive other people experience in being with them. So those are critical warning signs that we need to be aware of. So knowing about risk factors, knowing about the scope of suicide, and that so many folks are impacted by it, knowing what to look for, brings us to the point of, okay, so when should I do something about it? And what can I do? And this is where, strangely enough, it's going to sound a little weird, this is the easier part. The harder part is learning and knowing all of these pieces that go into the assessment, so to speak, that someone might be at risk. But we use a really simple kind of a phrase that says, if you see something, you see any of these warning signs, these behavior changes, you hear any of those expressions of distress or worthlessness, say something. Be willing to be the one who reaches out and asks the question, are you thinking about suicide? Hey, I'm worried about you. I've seen X, Y, and Z, and I feel like you're just not yourself. Have you been thinking about killing yourself? Is this something that you've thought about in the past? Have you ever tried? Being comfortable with directly asking those questions and being the one to ask the question first, that is critical. And this is probably this asking the question, not being afraid to ask because you think they might say yes and you don't know what to do. That's the most important gift that you can give to anybody, is to ask that question, because folks who are feeling the guilt, shame, worthlessness, sense of being a burden, who are in the throes of those distressful and depressive emotions and are considering suicide, are probably not going to be the ones who bring it up and tell you first. They're just not. In fact, many people who are suicidal, because of their shame and their guilt and the stigma, work incredibly hard to hide all of these emotions and feelings, to come across as being in control and not needing help. They work very hard at that, so they're not going to let that slip. But if you're the one who is comfortable to asking those questions, to listening to them without making any judgment, to ask the question from a caring and loving place, not to say something like, well, you're not going to do something stupid, are you? Because what does that, say to someone who already feels shame and stigma? Well, yeah, I guess I'm not. I guess I am stupid. I'm not going to talk to you about it. I'm not going to bring it up to you, am I? That shuts down the conversation. You may not understand it. You may not share their feelings or their perception of how bad things are, but you're willing to listen to them, really listen, actively listen, to hear the emotions and the feelings that are behind whatever the situation is that they're in. And some people are in really bad situations, but it's not the situation itself that's gotten them to the point of seeing suicide as their only option. It's the emotions and the feelings that are about their situation that have gotten them there. So listening to their pain from their perspective, hearing their story, validating their emotions without, playing into them or saying, oh, well, yeah, you're right. Your situation is really awful. I guess I'd want to kill myself too. No, we're not talking about that with validation, but just acknowledging and recognizing that they are in pain, regardless of why, of what got them there, what has or haven't happened, what they did or haven't done to make it better, what they've tried or not tried, doesn't matter. Just listening and hearing their story and not judging, not shaming, really can make the difference for someone between life and death. And for them to stop trying so hard, putting all their energy toward hiding these feelings, but to feel safe that you are a person with whom they can share and not risk more loss. And that helps build trust. You're being open, you're being honest, you're not showing shock, you're not shaming them further. And you know what? We don't want to give advice either, because a lot of times, most of the time, we find that people who have made, negative choices that have adversely impacted their lives and put them in a position where they think there's no out. They know that. They know what they should have done different. They understand those pieces. They don't need that to be, told to them. They don't need glib reassurances of, oh, it's not as bad as you think. And we tend to do that a lot with young people. Like, you got your whole life ahead of you. Well, they think they don't. They're feeling helpless. They're feeling hopeless. They think they can't ever change. So they don't have their whole life ahead of them from their perspective. And if they hear you say something along those lines, or some sort of, it gets better, you're going to be fine, you're strong enough for this, all that reinforces to them is that something's really wrong with them if you think that, because they don't feel that way. And they can't get themselves to where they feel that way right now. So that just being there, working with them from the position of what they feel and see and hear and are experiencing, that's how we're collaborating with that individual to help them feel a connection and a possibility for safety. And we want to do this from their perspective and to meet that individual where he, she, or they are. And we don't have to know, again, everything to do to make it better in the long term at all. That doesn't matter. What matters in that moment is your compassion and how powerful that can be to help the individual have at least this tiny little bit of hope that maybe, just maybe, there's some light in that tunnel vision that they're experiencing. Maybe suicide is not the only option. Maybe there are some others that I don't know about, I haven't thought about, or that I can at least be open to listening to what you have to say that might help me be able to identify that I do have somebody in my life that supports me. You support me. You're here. That maybe I do have, some strengths that I didn't realize. And I can tell you this from 34 years of crisis counseling. Even the person who is at the most intense moment of carrying through on a suicide attempt, even people that would call us on our hotline and would tell us their situations, and in our human brains, we'd be like, oh my gosh, if I was experiencing all this, I don't know how I would stay alive either. That's a place where you can meet people, because what you can say to somebody is, if they've been through that much awful stuff and they're still standing in there today to talk to you, they have coped and they have survived and they have existed somehow. Ask them how they got there. Ask them, how have you managed to be here until today? And the person is forced then, in a sense, to admit, well, I am still here. I did survive. And to look at what might be those coping skills that they've forgotten, what might be that value, that piece in there that still wants to live. That might be the way that they connect to that, and that they are open to having you help them, reduce their access to put the gun down, to lock the gun up, put the pills away, let you make a connection for them, let you help guide them to a people and a place where they can get the ongoing help they need. What is that next level of care? Because it doesn't have to be you. You don't have to be the next level of care. And in many cases, you're not. You need to be able to be open to saying, I don't know how to make this better, but let me help you find somebody in some place that maybe can. And then make a connection to that individual with the most appropriate organization, agency, provider who might be able to give them the least restrictive care, and to be able to make that contact with them that shows them that there is hope and the help is actually out there and a possibility. Ask that person to just give help a chance for a minute. They gave you a chance by letting you ask the question and accepting that you wanted to be there and help. Maybe other places can help as well. So what you can do is be aware of resources. And what I want to tell you today is a primary resource that we hope that you will use, that will help you feel more comfortable, like, hey, I've got help when I want to make a difference in somebody's life. And it's a really simple 3-digit number, 988, that many of you, I'm sure, have heard of, that is answered in Louisville here through 7 counties through our Crisis and Information Center. And 988 is available 24 hours a day, 7 days a week, 365 days a year. We never close. All services that we provide are free, and all services are confidential. And in most cases, unless someone needs immediate rescue because they've got a gun in their hand or they've taken an overdose, everything is anonymous. For us to talk to an individual who's hurting or in crisis, we don't even need to know their name. And services are available through the Lifeline in English and in Spanish, but we also connect with language line solutions for a translator. So we can talk to folks who converse in over 240 different languages and dialects, so that services are available around the clock, no matter what a person's chosen language is. And 988 is available not just by phone, by calling those 3 digits, but it's also available for anyone 24/7 by texting 988. And a lot of young people are much more likely to text than they are to pick up a phone and call. Or folks can go online at 988lifeline.org/chat, and they can chat with a crisis intervention counselor immediately, 24 hours a day. For folks who are deaf or hard of hearing, They can access 988 through a video phone or through their preferred used relay services. So services are available around the clock in all these modalities for anyone who might need them. There are even for our special populations, there's a veterans crisis line option where folks can call and press 1 and be connected to a veteran peer, or Spanish speakers can press 2 and be connected to a Spanish speaking individual peer that they can talk to in their language. And when you call 988, we can offer an array of services to individuals, everything from talking to one of our trained crisis counselors in the here and now to services for third parties. And this is where it's a help for you. You've got somebody that you're caring about and concerned about. You've asked the question, they've said yes, and you don't know what else to do. Call us. We love for third parties to call us, and we can reach out to that individual. You can put them on the phone with us, make that warm connection. We'll talk to them. We'll provide resource information to you. We'll tell you about all the mobile services that 7 Counties offers, or all the treatment services that we might be able to connect folks to. 7 Counties can make treatment appointments now 24 hours a day, 7 days a week. But if 7 Counties is not necessarily the best resource, at 988, we can also access a database that literally has several thousand local and statewide sources and the resources in there. So we'll connect people to the underlying and current need services that best meet their problem where they are. Doesn't have to be a 7 County service at all. We can make those connections for folks. We can make those connections for you. So not only are the individuals who might be experiencing a suicidal crisis, not only is help available for those folks, but help is available for you as the helper so that you don't have to go it alone. You never do. We're there. We want to be able to help. And if you need more information or you would like more training about what we've talked about today, I have my information here on the screen where you can reach me. My what's it called? Email, grobinson@7counties.org. I'm also going to make these slides available to anyone who would be interested or wants them. I will give these slides to Laura, and Laura can make them available for folks as you would like to have them. Questions that I might be able to answer in our remaining time.
Let's see. Well, there it went. Walter had a question that he typed into the Q&A.
Okay.
All right, where'd it go? About kids who leave the facility, the mental health facility, and then go back home, back into the unstable environments that they were in before.
Yeah.
How do you help them move forward, but once they've achieved some stability, but go back into that unstable environment?
One of the main things I'd say is that just shows that importance we talked about how when people begin to get treatment and help, but they haven't fully realized, getting to that point where they are able to cope independently, that we have to continue providing the supports. And we also often, for instance, when someone calls in, if you were to call us, Walter, and tell us about this situation and ask us to reach out through the crisis line, we would not only reach out and provide support and services to the child, but we would also attempt to do so for the family. For the folks who were part of that situation that they're going back into, to try to help educate them to understand so that they can support what is happening for them in their professional setting. But one thing that's great about crisis services is we can talk with the child and provide support to that child, even over the phone, even without parental consent. So we don't have to have a parent be involved. We can still call. And one thing that the crisis line can do for folks is we can provide ongoing contacts. We do follow-up. So it's not just the first time maybe that we talk to an individual, but we can continue to do follow-up for them through a period of time, whatever that time might be, so that we can ensure that they have ongoing support and ongoing safety. Someone has eyes on them and is helping them out and is going to be aware if they begin to have higher risk factors. So we're more than happy to do that and to arrange possibly even for additional services through some of our child crisis care services to also provide those supports in addition to what was being supported at the facility.
All right, thank you. And then someone, Mohammed, raised their hand and had a question. I've allowed you to talk, Mohammed, if you would like to ask your
Yeah.
question.
Hi, Mohammed.
Uh, Hi, Geneva. This is important information that each community needs to have. So I have a couple questions on this. Question number one is, how much of this data that you shared is immigrant and refugee population reflected on that data? Do you have a data for that? That's another way of asking that question. And one request that I have is, as far as the populations that I talked about, talking about mental health, talking about suicide, that is a taboo and it is not
Yes.
talked about. So I personally and other folks wanted to make sure that there is education piece to these communities, that the parents, we see a lot of rates when it comes to the youth and young adults that are committing this part in the refugee and immigrant population. So I wanted to take the initiative of putting a material together, curriculum together, to educate them on, oh, there's help out there. You can ask for help and all those stuff. That way they will be seeking for it. So for populations that are already educated, and this is not a taboo, that's okay for reaching out to the 988 number and asking for help. But what we, as a refugee population, we are experiencing is more problem, whereby understanding that there is help out there and we can ask for help. So I wanted to be that person where I can educate these populations to ask for help. I don't know if
Well,
that
I
makes
think that's awesome. And one of the things that's most important when we're reaching out to refugee and to other ethnicity and populations is that we don't try to be the experts on other cultures necessarily. We respect and we learn what we can, but we want to work with you collaboratively to help craft messages that can be heard by and understood by and accepted by, or trusted, I guess is a good way to say it, by folks for whom this is a more difficult topic, for folks who have their own cultural biases or their own cultural, as you said, taboos about this. We want to work alongside folks who are embedded in the community and in the understanding so that we are talking the language that we need to reach these individuals. So we're happy to do that. I would love to do that. There is not as much research, I'm going to be very honest with you, in this field for populations outside of white, Black, and Hispanic. There's less population, but there's beginning to be more of a push to have that research and that information. And I will say that a bit of the research that I've talked about on here that was through the Jefferson County Suicide Fatality Review Board, that did not go beyond sort of those basic populations. However, Jefferson County also has a behavioral health coalition that meets quarterly. That is bringing together folks and focusing on making sure that we have culturally appropriate messages for folks and that we have culturally appropriate avenues for people to reach out for services. And I would be more than happy if you want to drop me an email, Mohammed, to connect you with some folks within our organization who are working very hard to make sure that we are considering the cultural needs and crafting our messages and our treatment services in a way that will work for different populations. The third thing that I will say quickly, we do find that when we have someone who's a part of the community who vouches for us and our services through 988, and for the confidentiality and the anonymity, we do find that more folks are beginning to reach out from marginalized groups and from other communities that normally would never be seen or heard reaching out for help because of that taboo. But because we don't even need to know your first name, we don't have to know anything to provide you services over the phone. More folks seem to be comfortable with reaching out and at least finding that it's safe to ask for those services. So thank you. I appreciate that. It's a very needed area.
Appreciate it. Thank you.
All right, other questions or comments? Our time is about out, but I don't want to cut anybody off either.
And as I said, you have my contact information. There's no dumb question. If you want more information or you want to, call me or send me an email, I'll be more than glad to meet with you, to talk with you, to answer any other questions that I can, or to kind of connect you to it if I don't know the answer. So.
All right, well, thank you everybody for your participation and your attention today. Very
Yes.
important topics that Geneva's covered. And, Geneva and I go way back. We were babies, infants.
We were, weren't we? I
In another
know.
life. Yeah. So I'm just delighted that she was able to present to us today. You will get a request to complete a survey for the coalition on your experience with this particular webinar. Please fill that out. We do take these seriously. We take your feedback seriously, and we will make adjustments and changes or keep things that seem to be working for everybody. So please, please, please fill that out. I will send you the slides when Geneva gets those to me. And please don't hesitate to reach out to her. As I said at the beginning, she is passionate about this topic. She is a local resource and expert, and she will do whatever she can to help educate and empower you and your staff and your clients in this. So thank you, everyone.
Absolutely.
Have a great day.
Thank you. Thank you for having me. And thank you everyone for taking the time to listen and to learn and to be willing to make a difference. I really appreciate it.
All right.